Good afternoon, everybody, from a very cold and wintry Cape Town. We've got a great session this afternoon from colleagues here at UCT, and the title of today's session is Micronutrient Deficiencies, a deep dive on iron and copper. My name is Jessica Opie, for those of you who don't know me. I'm the head of hematology here at UCT. And I'm just going to be running through some slides, and then I will introduce our first speaker. So the Blood SA Foundation, which sponsors this Monday deep dive session, originates here from UCT. And the management team, it's led by Professor Estelle Verburg, and Dr. Nicolai Smith is our National Outreach Officer. Housekeeping notes, all of these sessions will be recorded, and you can find them on the website later if you have missed anything. Please mute yourself during the presentation to ensure that there are no disruptions to the speakers. You are very welcome to insert questions into the chat. We would really value your interaction and questions. CPD points will be available as usual, but you do need to attend for 1 hour, and you need to make sure that your HPCSA number is entered correctly with a space after the MP for it to register. We would very much value your feedback after the talks. So please do fill in the questionnaire. Upcoming events, we've got the 2026 Physicians Conference in Stellenbosch, which is coming up 4th to the 6th of June. The SASMO, that's the South African Medical Oncology Society, in August, and the South African Stem Cell Society meeting is also coming up in July. And of course, the very popular and very excellent Hem-Onc meeting, 2nd to the 4th of October, which I hope a lot of you will attend. It's always absolutely excellent and held at Century City. Next week, Tygerberg will be presenting, and we have a speaker, Dr. Ruby Parasad, who's going to be speaking about a practical approach to key diagnostic modalities in the hematology laboratory. For today, our topic is micronutrient deficiencies, a deep dive on iron and copper. And it's really fantastic to have David Richardson, Daleen, Kriel, and Jody, Rusch speaking today. In fact, it will be David first, then Jody, then Daleen, followed by a general Q&A and closing. I'm going to start off introducing our first speaker, who is David Richardson. He is a hematology pathologist who qualified here at UCT, and he's now doing a PhD in hematology at UCT. And his research focus is understanding and improving outcomes for hematological malignancies in resource-constrained settings. His academic interests include improved diagnostic pathways, strengthening research and health systems, and greater efforts in collaboration to enable the pursuit of that which experts believe will benefit their patients. His previous research, which is what he'll be focusing on today, examined biomarker thresholds for iron deficiency in inflammatory states. Outside of work, he is a son, a brother, a husband, and a father. Welcome, David. If you'd like to share your slides, we look forward to your talk.
Hi, Jessica. Thank you very much for the introduction. And can you see my slides?
Yes, perfect. Thank you.
Perfect. All right. Thank you, and good afternoon, everyone. Thank you again for the introduction, and the Blood SA team for hosting us. I'll be speaking about our paper From the Marrow to the Blood, Optimizing the Diagnosis of Iron Deficiency in the Setting of Inflammation, to warm everyone up to this topic. So firstly, sorry, the slides, of course, are just lagging. There we go. A brief case presentation. Mr. TC is a 35-year-old male known to be HIV positive, but virologically suppressed on treatment with a CD4 count of 181. When he presented, he had fatigue, loss of weight, and abdominal pain, and was found to have marked pallor, wasting, and hepatosplenomegaly on examination. His full blood count showed a reduced white cell count and reduced hemoglobin, but the MCV and MCH were normal. The platelets clumped initially, later proved to also be reduced, so he did have a pancytopenia. And his iron studies showed a mild reduction in the serum iron, as well as transferrin saturation, but perfectly normal ferritin levels, very comfortably within the reference interval. As you, of course, no doubt suspect, given the topic of today, he later on did turn out to have bona fide iron deficiency anemia with absent stainable iron on his bone marrow aspirate. This means that iron deficiency, although not the only cause of his anemia, was a significant contributory cause. This brings us on to the broad picture of iron deficiency anemia. Facebook, WhatsApp, and Instagram all hold a certain title of apps with greater than 2 billion daily users. And sadly, iron deficiency is part of this crew, with 1 billion patients having iron deficiency anemia and a further billion having iron deficiency without anemia. This topic is important because, firstly, of this great scope, but secondly, because it affects patients. As you can see, that list of symptoms there can significantly impair quality of life and is present not only in iron deficiency anemia, but also with iron deficiency. And thirdly, this topic is important because diagnosis of iron deficiency can help lead to diagnosis of the underlying causes of iron deficiency. And lastly, important because while that picture on the right may be familiar to many a hematologist with those microcytic hypochromic cells in contrast to our small mature lymphocyte, that is the end of a process that starts with iron deficiency with symptoms and then leads to reduced production and the well-known reductions in MCV and MCH that we are so familiar with. But the problems start much earlier. The problem gets worse when we consider that if a patient has no iron and they do have inflammation, we are faced with a diagnostic challenge. And this is because not only do the MCV and MCH drop gradually and are not seen initially, but the common markers that we depend on, such as transferrin and ferritin, are acute phase reactants, meaning they do not reliably show us iron deficiency in the normal reference ranges in the presence of inflammation. Sorry, just waiting for the slides. How do we overcome this problem? The gold standard for diagnosing iron deficiency is the bone marrow aspirate and trephine, but you would have a hard job convincing your patients to come through to E5 to have their bone marrow just because you're not sure if their iron is low or not. For this reason, there have been a variety of approaches to try and diagnose iron deficiency in the context of inflammation. The one is to use non-standard parameters, like looking at the reticulocyte hemoglobin. This, however, has a relatively poor standardization of the cutoffs for diagnosis. Likewise, soluble transferrin receptor has poor availability and poor standardization of assays. The next option is to consider combinations of parameters, commonly looking at transferrin saturation or reticulocyte hemoglobin in indeterminate cases. And the third broad approach is to use a higher serum ferritin cutoff for a patient in whom there is evidence of inflammation. By way of example, here's the British Journal of Hematology guidelines, where they recommend that if anyone has a ferritin lower than the lower limit of normal of 15, they are determined to have iron deficiency anemia. If it's greater than 15, iron deficiency is ruled out, unless there's inflammation, in which case there's this indeterminate bracket of 15 to 150, where additional evidence is required to diagnose iron deficiency. For instance, blood film morphology, which we know to not always be reliable, the reticulocyte hemoglobin content, or a reduced transferrin saturation. Another approach is shown by the WHO, where they adjust their ferritin threshold upwards and say everyone with a ferritin less than 70 can be diagnosed with iron deficiency in the context of inflammation. This for adult patients. There are also disease-specific guidelines, for instance, in cardiac failure, renal disease, inflammatory bowel disease, but specifying these is beyond the scope of this part of the talk. However, even within the guidelines given by the British Journal or by the WHO, they acknowledge that their advice is based on limited available evidence and specifically highlight the fact that the studies which have ferritin or other iron status indicators and bone marrow iron content included are significantly lacking. And many of the studies rather depend on modeling or assumptions to reach their conclusions. Our solution was to do a cross-sectional study of adult patients who were undergoing diagnostic bone marrow procedures for other indications. We then specifically looked at classifying their iron stores, with everyone with grade 0 or 1 iron being deficient, as well as assessing their inflammation using the C-reactive protein, and then evaluating different laboratory markers to assess their predictive value and diagnostic accuracy. In total, we ended up with 97 patients with replete iron stores and 42 with depleted iron stores. This is of the total of 139 included. The first take home is that of the patients with iron deficiency, the median serum ferritin was 48.5. That's more than triple the lower limit of normal for ferritin. There was a high burden of inflammation in our population, with 72% of patients having a raised CRP. And it's also important to understand that our population had a high burden of malignancy in 81% of patients, as well as a high burden of HIV, which is obviously typical for our context in hematology clinics, but needs to be considered when applying these results elsewhere. And the next important finding is that reticulocyte hemoglobin was decidedly unhelpful in diagnosing iron deficiency in our context. You can see here in the receiver operating curves that in the context of inflammation, the red line, which is showing reticulocyte hemoglobin, had an area under the curve of 0.67, lower than the 0.7 that we would typically use to say a marker is helpful, but also significantly below that of ferritin. And indeed, ferritin was the single best parameter to diagnose iron deficiency, even in the presence of inflammation. You can see in the bottom figure how excellently ferritin performed with an area under the curve of 0.97 without inflammation, but also with an excellent performance even in the context of inflammation. The cutoff that we found for our total cohort to be optimal for diagnosing iron deficiency was 80, with a specificity of 94%, but sensitivity at 69. When we subdivided our population according to the presence or absence of inflammation, however, we found that that cutoff of 80 could be maintained for those without inflammation, and the sensitivity increased to 93%, importantly without a drop-off, but rather a mild improvement in specificity. For those with inflammation, the optimal cutoff could now be raised to 200, with again fair sensitivity and specificity. Furthermore, one of our other well-performing markers, the transferrin saturation, was shown to be beneficial in that when it was added for patients with inflammation at a fairly restrictive cutoff, so a transferrin saturation of less than 13%, we could maintain good sensitivity and significantly improve specificity for the diagnosis of iron deficiency. Based on this, we proposed that for all patients in our hospitalized population with a ferritin less than 80, this could be declared as being suggestive of iron deficiency. For those who have a ferritin above 200, iron deficiency is considered unlikely. Likewise, for patients with a ferritin above 80 without inflammation, iron deficiency would be considered unlikely, but importantly, not excluded. For those then with this indeterminate ferritin of 80 to 200 who had an elevated CRP, transferrin saturation was useful using a cutoff of 13, above 13 saying that iron deficiency is unlikely, or below that it is suggestive of iron deficiency. The strength of the study was around having bone marrow, the traditional iron markers, and CRP, allowing comparison across the groups of inflammation and to the gold standard. However, being in a high prevalence of malignancy and HIV scenario, the transferability of these results needs to be considered carefully, specifically given that these were primarily hematological malignancies. Going forward, it will be important to do more work looking to try and define these iron cutoffs in specific populations, so maybe to look more broadly at hospitalized populations with a lower burden of malignancy, and also perhaps in patients with HIV more generally, including hospitalized and unhospitalized patients, to better understand how to make this diagnosis. Before I close, I'd like to just take some time to consider some of our findings against the other literature. Our findings do align fairly well with some more recent publications on iron deficiency, where they are recommending higher ferritin cutoffs as being considered for patients with inflammation. So Capellini recommends a ferritin less than 100 could be diagnostic, and values of 100 to 300 you would require additional evidence, such as a reduced transferrin saturation, to make the diagnosis. The other key consideration is that higher lower limit for the diagnosis, where we found that the median was around 45 for patients with iron deficiency, and ended up recommending a cutoff of 80 with no additional tests. Trung et al. Did a review of ferritin reference intervals and confirmed that the lower limit of normal, based on a meta-analysis for ferritin, was significantly lower than the 30 that many authors are starting to recommend as a cutoff. However, they do acknowledge in their paper that although the lower limit of normal is significantly lower than 30, the majority of the studies which have investigated these reference ranges have not adequately screened to exclude patients with iron deficiency, with only 10% of the studies including questions regarding menstrual history or bleeding history in general, as well as diet, in considering whether or not the so-called healthy controls could be used to determine the reference ranges for normal iron levels. Another important consideration when we consider the lower limit of normal is that other studies have also found that increasing the lower limit from, in the study, 12 to 30 resulted in a significant improvement in sensitivity. So picking up an additional almost 70% of patients with iron deficiency without significantly reducing specificity. And last of all, a general review from the New England Journal indicating that for the general population, a ferritin cutoff of 30 is recommended. So with this background as a slight build-in to the next talk, I'd like to thank you all for your time and hand back over.
Thank you very much, David, for this excellent overview and presenting your fantastic MED project, the results of your MED project. There is one question/comment that's come up from Dr. Jacques Malherbe. Jacques, I'm not sure if you'd like to unmute and just explain your question. Or otherwise we can leave it to the end. Okay, I'm not sure if Jacques can hear me. Well, I can also just read it. It's a patient with CMML in blast phase has no stainable iron on the current bone marrow with a ferritin of 928, transferrin of 0.98, serum iron 22.7, and transferrin sats of 91%, hemoglobin 7.4, MCV 109. Also has renal failure, suggesting one can almost never rule out iron deficiency. I wouldn't even have considered iron deficiency based on the clinical picture. I very confidently said at our academic meeting last week that I don't think you really need tests like the soluble transferrin receptor, as I've always believed that the basic tests in conjunction with clinical acumen can almost always sort out this issue, only to be confronted with those results an hour later. Would you like to comment on that, David?
Yeah, thank you very much for sharing, Dr. Malherbe. I would definitely agree with you that there, yeah, we're very careful to include that iron deficiency is unlikely rather than excluded. In my cohort, there were patients with ferritins as high as 1,500 who had completely absent iron stores. And obviously, you wouldn't recommend a trial of iron therapy for a patient without evidence of iron deficiency based on those ferritin results. But I think a practical take home is to still keep iron deficiency in the back of your mind as a possible cause, and certainly revisit the issue once the acute phase has uh, resolved itself or been resolved through your treatment. And repeat iron studies post treatment might give you a very different result.
Thank you very much. Jacques just responded to say he's in the car and with his family and he didn't succeed in unmuting. I think what we'll do for the moment, so Jody makes a comment, I would repeat the iron studies and ensure that the sampling is fasted. That's a very important point, is when you actually collect the sample for the iron test. And I'm sure that Jody's actually going to go into that in more detail in his talk. So I'm going to move on to introducing Jody now, and thank you very much, David, for an excellent presentation, and we'll go back to further questions towards the end. So big welcome to Jody, who is Jody Rusch. He's a chemical pathologist here at the NHLS and UCT. His work includes laboratory management, diagnostic service delivery, test interpretation, research and development, and training of undergraduate and postgraduate students. His academic interests include a center on clinical chemistry and patient care, laboratory test utilization, automation, and improving diagnostic efficiencies using large laboratory data sets. He has a particular interest in iron studies and applying data-driven approaches to optimize diagnostic thresholds. He enjoys translating complex laboratory data into clinically meaningful insights. And his other interests outside of work include hiking, making music, and bonsai. Welcome, Jody.
All right. Thank you very much for the introduction. And thank you, David, for an excellent talk. Really enjoyed that. So I'm a chemical pathologist, and I realize I'm speaking to hematologists, so please forgive me if I misstep. But my talk today is about rethinking iron studies. There's a sort of subtitle of From Statistical Normality to Clinically Meaningful Decision Thresholds. And it's essentially a talk about modern interpretation and what the recommendations may be. I'll be discussing kind of some of the recommendations that are coming out from different bodies, including our own working group in South Africa, where we're trying to put together a robust document that can guide this conversation in our local setting. Just trying to get this to move forward. There we go. All right. So with any talk, it's always important to explain why this talk matters. And I think that from various sources of evidence, we know that iron deficiency is a very common problem globally. And we know that non-anemic iron deficiency has been under-recognized and undiagnosed historically, and probably even currently. We also know that laboratories and the results that they put out heavily influence diagnosis, and this is incredibly important when it comes to reporting practices. And while laboratorians may take that very seriously, it's important that everybody, the clinicians included, also understand how important reporting practices may be and how they may influence diagnosis. We know that traditional ferritin reference intervals miss clinically important iron deficiency. And we know that identifying and treating iron deficiency, as well as its cause, is essential if we're going to ensure optimal patient care, safety, and health equity. So the key takeaway here is that the lower limit of the reference interval is not the optimal diagnostic threshold. The high prevalence of iron deficiency does not rationalize it as a normal condition. So some of you may have seen that the American Society of Hematology released draft recommendations for diagnosis of iron deficiency in the sort of second half of last year. These guidelines are based on a systematic review of the available evidence. And they have a structured process, and they have a guideline panel who then makes judgments about the evidence, and they form recommendations. The public comment period for the draft was in September, October last year, and so that's ended. And the next step will be to see the publication, the official publication of the recommendations. So what I'm showing you is not the official publication yet, it was the draft. And what we can tell from this is that there is an emerging consensus in adults that a ferritin of less than 15 is just way too insensitive. A ferritin of less than 30 improves the diagnostic sensitivity substantially, and that a ferritin of about 50 may be appropriate in symptomatic or high-risk patients, in pregnant patients, in patients with heavy menstrual bleeding, and in patients with ongoing iron loss. Furthermore, this ASH draft recommendation highlights the context dependency. And as David explained, inflammation and chronic disease influence quite heavily the results that you obtain, and therefore we need to interpret them within the context. Even in a patient with inflammation, ferritin can be a very, very useful marker, but you need to change the threshold to an appropriate threshold for that clinical context. So with this in mind, you may then use ferritin fasting T-sets. And if you don't do a fasting T-set, you can't interpret the transferrin saturation. It's a calculation based on iron and transferrin, and it's quite diet dependent, and there is also a circadian rhythm to it. So the best thing to do is to try standardize iron study testing to fasted studies that are done in the morning. You may also want to include a CRP as well as the clinical context of your patient. So what you see then is ASH recommending that in patients with inflammation and chronic disease, you should measure both ferritin and transferrin saturation. And if the fasting transferrin saturation is less than 20%, or the ferritin is less than 100, that is indicative of iron deficiency. It also recommends that there are disease-specific thresholds. And again, it's outside of the scope of this talk to go into those, but these should be considered on a disease-by-disease basis, really. There's also an overarching good practice statement, and I'm not sure how this lands with hematologists, but when I was taught hematology, we started with the idea of, is the patient anemic? And then you go down the iron deficiency pathway. I would like to contend that we should be saying, is the patient iron deficient? And thereafter looking for anemia. And so there's an overarching good practice statement from the American Society of Hematology, which says clinicians should perform serum ferritin to evaluate iron status. A complete blood count, or in our context, a full blood count alone, is not adequate for identification of iron deficiency, irrespective of the presence or the absence of anemia. So we need to take a step back. Why is there controversy? Why is this complicated? Why are we here today discussing this? And the first thing to discuss is how were the reference intervals for ferritin first derived, and what are the issues therein. So David's mentioned some of them, but it's good to repeat some of the points. And traditionally, reference intervals were performed on what is seen as apparently healthy populations, but iron deficiency is highly prevalent in populations, and there was inadequate exclusion of iron deficiency in the population studied for this. They essentially looked for an absence of anemia. And the whole studies were really anchored into this idea that there's an absence of anemia. So while anemia or iron deficiency anemia is the severe end stage of iron deficiency, you are including two stages of iron deficiency if you're only excluding patients based on whether they have anemia or not. So iron deficiency, as I said, is highly prevalent in our populations. And so traditional reference intervals actually probably partially encode chronic physiological iron loss, like menstrual depletion or so, into the reference interval. The second point, not to confuse everything, but inflammation was often not excluded. And so what you end up with is a quite heterogeneous population, which gives you meaningless reference intervals and unreliable clinical decision limits. So not very good quality at all. And the key takeaway here is that traditional ferritin reference intervals were never designed to function as optimal clinical decision thresholds for iron deficiency. Statistical normality does not equal physiological adequacy. Common is not the same as optimal, and inflammation complicates interpretation. The word on diagnostic thresholds, we must consider that there's two different questions here. What is a statistically common is what a reference interval is. It's usually in a normal population or a healthy population. And that's not the same as at what ferritin level is iron deficiency likely in my patient, which is a clinical decision limit. So ideally for clinical decision limits, these need to be based on diagnostic accuracy studies and the performance of the test. And we then end up with metrics like sensitivity and specificity, and there are several others. And you saw some of those in David's study. We also want to ideally base clinical decision limits on the clinical outcome of the patient, as well as their response to therapy. And, the gold standard would be to correlate with bone marrow iron depletion. But that's not very easy to do, especially in healthy populations. But I think it's important to take away that a ferritin of less than 15 really often identifies very advanced deficiency, and it's very specific for that. But then you're missing a whole lot of important patients that could benefit from treatment. So further issues with the ferritin reference interval. The reference intervals actually vary quite markedly between labs, with the lower reference limit being anywhere from 10 to 12 to 15 to 20 to 30. The variability like this suggests to us that the lower limit is not biologically robust. It probably reflects historical convention more than anything else. And there are other test issues like standardization. And we don't have the time today to go into that, but there are some references at the end which do. Bone marrow correlation studies actually support higher thresholds, and David's study is one of those. Symptomatic patients are often symptomatic despite ferritin values which are actually within the reference interval. And though those symptoms can be vague sometimes, they should not be ignored. Reference intervals may not reflect modern concepts of functional iron deficiency and iron-restricted erythropoiesis, as well as inflammatory iron sequestration. And then the last issue is that thresholds, the more we understand and the more we know, the more we see that thresholds are context dependent. So in inflammation, in pregnancy, CKD, heart failure, oncology, autoimmunity, thresholds may not be the same in any of those conditions. The key takeaway here is that within the reference interval may not actually equal clinically adequate iron status. David mentioned this study, but it's good to point out that while the Parker study references it, it's actually referenced from the Mars study in 1998. So we've known this for a long time. If you use a ferritin cutoff of 12, the sensitivity is very low and the specificity is very high. But if you increase that cutoff to 30, we gain a huge amount of sensitivity in the testing, while the specificity does not significantly change. Here's another study by Martins and colleagues from recently, which shows how this issue is becoming a global and sort of important issues with campaigns in some countries, and we'll mention one of those later. But what this study's take-home messages is that the ferritin is really the single best test for identifying iron deficiency, even in potentially inflammation and so on. Obviously, other than the gold standard, which is the bone marrow, but that's not an appropriate test for routine use. Ferritin really outperforms all others, and we saw that in David's study. 30 to 50% of apparently healthy women actually have absent bone marrow iron stores. And there is no physiological reason that ranges of normal serum ferritin should differ between men and women, where we see references are often quoted as being different, and this sort of concept that physiologically that makes sense, there really isn't any value to that. There's multiple lines of evidence, according to the study, that support a ferritin of around 50 micrograms per liter as a cutoff. They quote iron absorption normalizes above 50. Biomarkers such as hepcidin and soluble transferrin receptors support this threshold, and they found that symptoms improve when ferritin rises above 50. We don't have time to go through all the different conditions, but I would like to mention the study on pregnancy by McCarthy and colleagues. We know that iron deficiency has potentially serious consequences for perinatal and infant outcomes. In the study, McCarthy et al., it was a longitudinal pregnancy cohort where they had 629 pregnant females. And what they saw was that iron deficiency increased markedly during pregnancy. By 33 weeks, if you use the low cutoff, very specific and not very sensitive of 15, 51% were deficient. If you use a more reasonable 30 as the cutoff, 84% of pregnant women were iron deficient by 33 weeks. They found, using rock curve analysis, that a ferritin of 60 at the 15-week mark could predict iron deficiency in the patients in the third trimester, and it could predict it when they used the ferritin cutoff of 15, so very low. And the last sort of takeaway from this study was that hemoglobin alone missed substantial iron deficiency, and it's probably an inappropriate way to try to screen for iron deficiency in pregnancy, although it's what we commonly do. The key takeaway here is that many women who appear iron repeat early pregnancy progress to clinically important iron deficiency later in gestation. So I think everyone on the call will understand the problems with inflammation and how it changes interpretation. But just a quick reminder, inflammation leads to an increase in hepcidin, which leads to iron trapping in macrophages and hepatocytes. Ferritin is also an acute phase reactant, so you have an increase in ferritin, you have decreased circulating iron, and a decrease in TSAT. So then a fair sort of algorithm is that in inflammatory states, chronic disease and malignancy, ferritin alone may become misleading when you're using lower cutoffs. By including the fasting TSAT, it becomes more and more important in trying to interpret what the iron status of the patient is. And then interpretation must be contextual. So a very simple algorithm, but I think clinically meaningful. So last year, we published a paper, Old Tests and New Paradigms, and proposed this sort of algorithm for testing. So if you think that the patient may have iron deficiency anemia or iron deficiency, you have some tools that are easily available. You have the full blood count, you have ferritin, you have TSAT, and you have the CRP. The ferritin is less than 30. We thought that absolute iron deficiency is confirmed. If the ferritin's more than 30, you start to consider the clinical context. Is there acute or chronic inflammation, including congestive heart failure, CKD, IBD, malignancy, and others? Is there a raised CRP to help you with that? Or is the patient over the age of 65? If it's yes to any of these questions, then you look, is the ferritin less than 100? And if it is, it confirms absolute iron deficiency. So ferritin's between 100 and 300 and the transferrin saturation is less than 20, it confirms absolute iron deficiency. If the ferritin is more than 300, you should consult your disease-specific guidelines. Otherwise, iron deficiency may be unlikely. If none of those previous questions were yes, then we can go down to the next block. Is the patient anemic? Do they have a risk factor for iron deficiency? Are they pregnant? Do they have a low MCV? If any of the answers to this is yes, then we may consider that a ferritin of less than 50 confirms iron deficiency. If ferritin is more than 50, then iron deficiency may be unlikely. And then if none of the above and ferritin is more than 30, then perhaps iron deficiency is unlikely. Yeah, perhaps. So in our working group, if I summarize sort of the key recommendations that we're hoping to make, it's that non-anemic iron deficiency matters. We should consider symptoms and risk factors in our patients. We should use appropriate clinical decision thresholds and not reference intervals for ferritin. In general, ferritin of less than 30 in adults and less than 20 in children. We should interpret iron studies in the clinical context. Is this an adult or a child? Is the person pregnant or not? Is there inflammation? Are there specific disease states? And then we should use fasting TSAT appropriately, and we may consider using CRP if needed. The TSAT of less than 20 is clinically important. It specifically supports iron deficiency diagnosis when the ferritin lies in the gray zones that we've seen. And it's particularly useful when ferritin is somewhere in the 30 to 300 sort of gray zone, when the patient has proven inflammatory conditions or other conditions. And then the final thing is that harmonized interpretive comments will improve patient care. So this is our current draft table. It has to be sort of a fairly robust table that isn't too extreme, because we do see this as an iterative and stepwise process, while the evidence continues to be put together. So these are diagnostic thresholds and interpretation of iron studies for iron deficiency. We take the clinical context into account in a general adult, including pregnant women. If the ferritin's less than 30, it's iron deficiency. If the ferritin's 30 to 100, but the TSAT's less than 20, that's iron deficiency. In adults with signs and symptoms that are associated with iron deficiency, if you use a cutoff of 50, that's iron deficiency. If it's 50 to 100 and the TSAT's less than 20, that's iron deficiency. Adults with inflammation or a CRP more than 5, if the ferritin's less than 100, that's iron deficiency. If it's 100 to 300 and the TSAT's less than 20, that's iron deficiency. And in adults with chronic diseases, it's really important to start to look at higher thresholds that are disease-specific and guidelines from those specific bodies that should be publishing those disease-specific guidelines. So I just want to end off by summarizing that there's an emerging paradigm where diagnostic thresholds define deficiency. Ferritin is interpreted with transferrin saturation, importantly fasted transferrin saturation, plus minus CRP, as well as the clinical context. We want to detect non-anemic iron deficiency and treat it as appropriate, and we want harmonized interpretive reporting. So we're not the only ones. There's many, many groups around the world that are trying to essentially raise the bar. This is the Canadian group. And so the Raise the Bar initiative essentially emerged from the growing paradigm shift away from population-derived ferritin reference intervals towards clinically meaningful decision thresholds for iron deficiency. It was driven by essentially this mounting evidence that the traditional ferritin lower limits were contributing to underdiagnosis. And this was happening particularly in women. And the initiative brought together hematologists, laboratory specialists, health authorities to redefine how these ferritin results are being interpreted and reported. And importantly, this wasn't just an academic exercise. The initiative successfully implemented these thresholds across the largest outpatient laboratory networks in Ontario, which is the most populated part of Canada, most populated state. And it's coupled with abnormal result flagging, clinician education resources, as well as a public-facing knowledge translation tool. And the campaign framed iron deficiency not only as a laboratory issue or clinical issue, but also as a health equity issue, arguing that these outdated ferritin cutoffs had normalized iron deficiency and delayed recognition in treatment for many patients. Here are some selected references for this talk. And I'd like to thank you for listening and good luck.
Thank you so much, Jody. This was an absolutely excellent overview and very thought-provoking. And there are a number of comments in the chat. Just going back to Dr. Moses Chachambudza, who's given us a comment. As the hematology community, do we still think that bone marrow iron stain checked using the human eye should remain as gold standard for diagnosing iron deficiency? Or do we need a more sensitive method? And I think the answer is yes, we do definitely need a more sensitive method. And just to comment that in David's project, we actually had to exclude a lot of patients because we couldn't assess their iron stores on the bone marrow. So in cases where there are no bone marrow particles, we can't do a proper assessment. And also, if there are not enough particles to assess, then we also have to exclude those. But yes, even when we used those cutoffs that with the most sensitivity and specificity as per David's project, we still missed some cases of iron deficiency. With any further comments from you, Jody, on that before I move on to the next question?
No, I mean, I think your answer is really the point that we want to highlight is that the patient goes through quite an ordeal for a test. It's not an easy test to do, and then you still don't get an answer because you can't assess appropriately. That's the real challenge for me. It's one thing if you're going to perform a difficult test and you're guaranteed of an answer. It's another thing when you're going to perform a very painful, difficult test and you don't necessarily get an answer. So I think a lot of work needs to be done. There are obviously novel biomarkers on the horizon. There's also less novel, like soluble transferrin receptor, that we're starting to understand more about. And we look forward to sort of standardization of the test in the future and good, robust studies that can really inform what the clinical decision limits for markers like soluble transferrin are. It seems that in iron studies, it's often it may not just be one test that is important, but rather a set of tests that best predicts whether a patient has iron deficiency or not. And that's okay. It's okay to need 2 tests or even 3 tests in a model to do the prediction. But the question is always, how do you test that model without the gold standard? And bone marrow is currently the gold standard. It has issues, though.
And then one last question before we move to Daleen is from Jacques, who's always very interactive on this platform. He's saying, if we do see stainable iron on the marrow in patients with inflammation, does that rule out iron deficiency? How reliable an indicator of total body iron stores is the bone marrow? So no, if you see iron stores present in the bone marrow in a patient with inflammation, the patient could have functional iron deficiency and still benefit from iron therapy. It means that there's not absolute iron deficiency, but if you have met all the criteria and it's a good sample, etc. But if the iron stores are present, I also I think, and I'm sure Prof. Lowe can also comment on this, it doesn't mean that all that iron is actually getting to where it needs to go.
Jessica, sorry, I'm able to unmute
Yes.
now. I agree with that. It goes for me a little bit further than that, because I mean the majority of your iron stores is in the liver, and in the setting of inflammation, you may have a bone marrow that looks iron overloaded, and you make the assessment that the iron stores are normal, but as the bone marrow sort of hogs iron and it's the last place that becomes deficient. Yeah, it's actually more a question linking into Moses's thing that for me, the bone marrow, it's not the perfect gold standard, as we've already determined. I think if it's empty, and then you can clearly say there's no iron stores. But I think in my mind, I still have uncertainty if there is enough stable iron. It doesn't actually, or that's my thought, is that it doesn't give an overall view of the iron stores. I don't know if anybody has other comments or thoughts on that.
Vernon, I'm not sure if you're there and if you'd like to comment.
Hi, Jessica. Thanks very much, and thanks, Jody and David, for great presentations. Jock, I hear what you're saying. My understanding is that, and this is, I'm not a hematopathologist, and this is, I think, Jessica's domain and Daleen's and so on, but that in inflammation, the iron will get stuck in the macrophages in the bone marrow, which is where you will see it, and you won't see it in the red cell precursors. So my understanding is that despite those concerns, that it's still the most, let's say, organ-specific accessible iron that we can have, other than biomedical parameters or, biomarkers rather. So it is not, I agree, it's not perfect, but I don't think there's any other way to more definitively say that a patient's got iron deficiency in a direct way. I guess even doing a liver biopsy, I don't think will give you that much of a better answer. Maybe it will give you a better answer in iron overload, but in iron deficiency, I've not seen anything. Jessica, what do you think?
No, I agree with you. I mean, we see a lot of patients with functional iron deficiency. I think we can say if it's absent, it's very useful. If there is some iron or increased iron, I mean, generally we say that they are not iron deficient, but they can have a functional iron deficiency. And as far as I understand, that some of those patients can actually benefit from iron therapy in terms of their symptoms and their outcomes, cardiac patients and so on. That is my understanding. But I think we're going to have to move on now, because we've got one more speaker, Daleen Kriel, who's actually going to speak to us on a slightly different but related topic of copper deficiency. So I'd like to introduce Daleen and allow her a chance to talk. Of course, to thank the fantastic speakers we've had so far on iron deficiency, and then perhaps we can get back to any further questions in the discussion. Daleen is a consultant here with us, hematology pathologist at Richardson and Red Cross Hospital and the NHLS. She's a general hematopathologist, actively involved in morphology interpretation, consultative hematology, and workup of unexplained cytopenias. She's very interested in iron deficiency and values pragmatic approaches to everyday hematology questions. Welcome, Daleen. Over to you. I think you must just unmute.
That is true. That is true. I just want to check if we can advance the slides, which is always a bit of a mission.
You should be able to advance from your side.
Let's see. While I'm trying that, I'm going to just get started. Why does it have to be so hard? I am pressing every button. There we go. There we go. Thank you so much to everyone for your attention and for attending the session, and to Bloody SA for inviting us and for having me. I'm going to try my hardest to run through copper deficiency in 10 minutes. I think it is an important reminder for those of us who have worked in hematology for a while, and also important for all trainees to have a bit of a primer at least once during their training. So to start us off is a patient history and some details. This is a lady who was referred for a macrocytic anemia and leukopenia. She has a history of gastric resection 9 years ago for peptic ulcer disease. And this macrocytic anemia is such that she requires red cell transfusion every 2 months. And despite IV iron, oral iron, B12 and folate, no response, and that's the reason for her referral. So on the right, we can see her FBC, which confirms a neutropenia, severe anemia, MCV 102, and comparatively a better preserved platelet count. The film showed oval macrocytes, and again, they tested ferritin, B12, and folate, which were all high. And on her bone marrow, significant dysplasia of erythroid and granulocyte precursors with ring sideroblasts and a normal karyotype. Based on this, this patient was diagnosed with the previous refractory anemia with ring sideroblasts, so MDS. They attempted pyridoxine with no response, started GCSF and EPO, and then they saw increase in the white cell count, an improvement there, but although the HB normalized transiently, it dropped again after 3 months. In the interim, she developed optic neuritis and severe progressive peripheral neuropathy, and was then referred for evaluation for stem cell transplant. So we will carry on with this case a little bit later. This is just to get us started thinking about copper deficiency, which is probably a cousin once or twice removed of iron. So thinking about copper, it's an essential trace element that functions as an enzymatic cofactor and is essential for various systems, including the neurological and hematological system, which we will focus on today. Because it's quite ubiquitous, you can, in a general adult, obtain adequate levels from your diet. A standard Western diet, definitely. And for the purposes of your next big dinner that you will have for an anniversary, you can prioritize this set menu to get optimal copper at your meal. So you will include crustaceans and shiitake mushrooms, cheese, liver, dark chocolate, and nuts. So you don't need to get this fancy, but these guys are really high in copper. But in general, vegetables, legumes, and whole grains, you usually get more than enough. So as we can see on this diagram, if you consider your dietary copper and you see how much is actually lost or excreted in the end, with some from urine, usually your intake is more than you need. So it is quite difficult in general to become deficient, but we will see that there are patients who definitely do become deficient. So copper is mainly absorbed in the small intestine, then it travels through the portal blood, through your copper transporter 1, it enters the hepatocytes, and then importantly, it's incorporated into ceruloplasmin, which then allows traveling in the systemic circulation to the different tissues. As an aside, some of you might remember that ceruloplasmin is also a peroxidase, which helps to convert ferrous iron to ferric iron. So there is an important role for ceruloplasmin in allowing iron transport and the release of iron from the reticuloendothelial system. So this is why there's interaction between copper and also iron metabolism, which is why they are cousins in a sense. Looking at the hepatocyte and traveling, or the copper exiting to now be carried on the ceruloplasmin or being excreted into the bile. These release reactions or exiting is regulated by the ATP7B gene, and this might ring a bell that this is the mutated gene in Wilson's disease. So without proper functioning of this gene, your copper is trapped and you are then sparing and hoarding copper in your liver. And yes, then we can just consider in a little bit more detail what happens at the absorption level at the intrasite. So if we go to our next picture, which is a lovely one, as we know from the New England Journal of Medicine, we can recognize them. So if you look on the left-hand side, you've got your copper entering in your intrasite, and then it is chaperoned and shuttled with amino acid binding to reach the apical surface and then to go into the bloodstream. Another ATPase, this one is regulated by the ATP7A gene, has a role here. And if this one is mutated, not the one for Wilson's, but this one on the apical membrane, or that has its effect here, you can end up with Menkes disease, which results in the export of your copper from your intrasite not happening and trapping of your copper inside the intrasites. So these patients show, of course, copper deficiency and neurodegeneration, epilepsy, and kinky hair, you might have heard. So they are usually diagnosed in infancy. So that is, of course, one of the inherited causes for copper deficiency. Also in the intrasites, you've got binding of your copper to metallothioneins, and they are proteins that protect from oxidative stress and prevents free copper from damaging your intrasite. And this is important because on the right, when you've got zinc in the picture, so a patient taking zinc supplements, the presence of zinc upregulates these metallothioneins significantly, but because they bind copper more avidly than zinc, they are then binding copper and trapping the copper inside the intrasite, similar to what we're seeing with Menkes disease. And then when the intrasites are sloughed off, you lose this copper in the stool. And that is why patients with high levels of zinc, or we'll talk about zinc toxicity, can then result in subsequent copper deficiency. So considering the causes of copper deficiency, this helps us to think about which patients are at risk and which patients should perhaps be tested. So we touched on the hereditary causes. Inadequate intake and increased demand is not really listed as primary causes of reduced copper. However, if you think about malabsorption syndromes or conditions, it's very important to consider post-bariatric surgery, especially biliopancreatic diversion surgeries. There's also a variable number of patients in the literature that have celiac disease that are copper deficient. And of course, gastrectomy, patients with prolonged diarrhea, even patients with intestinal GVHD, you should remember. So in the context of reasons for malabsorption, this should prompt you to think about copper deficiency in your patient. And then, like we explained, excessive zinc ingestion. Very interesting for me was reading about denture fixatives or adhesives. If a patient has poorly fitting dentures, they might overdo the fixative or the adhesive. and patients have developed significant copper deficiency from this source. And as this paper shows on the left-hand side, a patient has died from this cause. Coming down the line, the zinc is too much, the copper is deficient, all the way through. Excessive oral supplementation of zinc. You can consider this in patients on dialysis for cirrhosis, of course, people with Wilson's disease, and in a situation like the COVID pandemic, where patients themselves decided, I want to boost my immune system, and they overdid the zinc supplementation. Important to remember, if you read about what is seen as an excessive intake of zinc, it's about 40 to 50 milligrams per day. And if you take this Zinplex, which is 20 milligrams per tablet, which is prescribed or advised on the container to be taken once a day, if you just decide you'll go twice a day instead of once, then you are already at the excessive level. So it is fairly easy to put yourself on an excessive zinc supplementation regimen. While we are talking about drugs, if you have a situation where it's difficult to determine what's going on, go into your patient history and really ask them about over-the-counter or traditional medicines even. Ionic colloidal silver, this is taken from the DISCEM website. There's also cases described where colloidal silver has dramatically impacted copper metabolism and led to severe copper deficiency. Lastly, patients on parenteral and enteral nutrition, where the TPN and what is given has got inadequate copper content, is also important consideration. So mainly post-bariatric surgery, some in celiac, but then consider other malabsorption syndromes, excessive zinc, and your parenteral and enteral nutrition. So although copper deficiency remains rare, it's important to consider it in the correct at-risk populations. Because it is rare, the prevalence and incidence data is a bit scarce, but in case series, about 6 months after gastric bypass, you can already see about 15% of patients have copper deficiency, much higher at 3 years. And remember that the onset of symptoms can be very long after the actual bypass surgery or gastric surgery that the patient had. So your symptom onset can actually be up to 20, 25 years later. So considering an increase in surgery for obesity, your TPN, your aging population, there is reason to consider copper deficiency in patients with anemia and neurology. So as we will see here with clinical features, if you consider varying degrees of peripheral neuropathy and also dorsal column dysfunction, you can see there's a distinct overlap with patients with B12 deficiency. You'll see here close to the bottom, clinically and radiologically, the picture is actually indistinguishable from subacute combined degeneration. Patients get tested for B12 or they just assume that this is B12 and keep treating it like the patient we saw in the patient example in the beginning. And of course, to make things worse, you might have copper deficiency that coexists with B12 deficiency. To add insult to injury, since we are pressed for time, I'm not going to spend time on the ataxia and the paresthesia. There might also be optic neuropathy, and then other problems like osteoporosis, skin depigmentation, fragile hair. Of course, the neurology is the most important and can be very debilitating. Hematology features, since we are hematologists, anemia is the most common, followed by your white cell count and your neutrophils dropping. Thrombocytopenia is less common. This is what we saw with our example case as well. The anemia might be macrocytic, as it was in that patient, or micro or normocytic, so that's not really helpful. Although, as we saw, the overlap with iron metabolism and the fact that copper plays a role in ceruloplasmin and also hephaestin, the incorporation of iron into your hemoglobin and your developing red cells is not normal. And that explains why we have anemia. You've in your bone marrow got features that overlap with MDS. So erythroid dysplasia, ring sideroblasts, a variety of other issues, increased hemosiderin. So the incorporation of the iron is not happening appropriately. It's stuck in the mitochondria. And then characteristically, cytoplasmic vacuolation. So we see up here red cell precursor with vacuoles, granulocyte precursor with vacuoles, very abnormal sideroblasts and also ring sideroblasts. And of course, then you need to consider copper deficiency in your differential of vacuoles in your precursors. Also, one of the newest kids on the block, the Vexus syndrome, has similar vacuoles in your precursors. But don't forget plain old copper. Investigating your patient, you request a serum copper. It costs 202 Rand. It's sent off to Pathcare. Quite similar reference intervals for men and women. Your urine copper and ceruloplasmin will also be low. Remember to test your other usual friends and not exclude them. Your zinc level is important if you suspect zinc excess. Important there is to remember with your zinc testing that this is also a type of acute phase reactant. So in a setting of systemic stress and inflammation, your zinc level might be falsely normal or even low. So don't misinterpret that and miss that it's actually a high zinc level. Consider your cause, so you can do serology for celiac disease, etc. And then on your magnetic resonance imaging and your other neurological studies, you will see the characteristic evidence of copper deficiency. So T2 weighted images on MRI, they show abnormal signal uptake. Almost done. So for treatment of copper deficiency, you discontinue zinc, you treat the underlying cause, and then you give your copper supplements. For mild to moderate deficiency, only oral. Severe, you can start with intravenous first, then go to oral. This is from the American Society of Metabolic and Bariatric Surgery. And then your blood counts normalize fairly fast and has got a very good outcome, but there's limited improvement with neurology. Unfortunately, your treatment will prevent progression. So coming back to our patients, lastly, during the pre-stem cell transplant evaluation, luckily, there was a nutritional consultation. A copper level was done and found to be undetectable. She was treated, her HB normalized in 6 weeks, FBC followed, bone marrow changes completely normalized, but her peripheral and optic neuropathies persisted. So last slide, why does copper deficiency matter? Besides being one of the very last things you remember on a list when you study, we can see that early identification can minimize the neurology that your patient experiences. And this neurology can be irreversible and debilitating if you don't consider copper deficiency. It is clearly a masquerader. It can be confused with MDS, B12 deficiency, missed and delayed diagnoses, inappropriate therapies, as we saw. There is in the studies I looked at a delay in diagnosis of 1 year up to 20 years of getting down to the fact that this is copper deficiency. Easily treated, and I believe that hematologists are well positioned to test for this and to advocate for a high index of suspicion in at-risk groups when you are consulted with refractory cytopenias or myeloneuropathy, and especially then in the context of previous surgery or zinc exposure. So that is my story. There's a lot of reading for you for over the weekend. Thank you so much for listening.
Thank you very much, Daleen. This was really an excellent talk. Really enjoyed it. Getting lots of claps and congratulations. Prof. Lowe said we really need to have talks on more on the role of these vitamins and minerals in hematology, like vitamin A, B6, C, D, selenium, magnesium, phosphate, perhaps for future deep dives. I mean, as you've spoken, I think that we probably really have underdiagnosed and probably missed a lot of these cases, because I don't think I've ever actually requested a copper level. And I think it's something that we all need to be alert to. And now that you have, raised it and indicated where we can test for it and how to treat it, I think one of the questions was, who has actually diagnosed a case? I do remember Vernon telling me that he had diagnosed a case in the past, but I think we are diagnosing it very rarely, but perhaps our index of suspicion is too low. I'm not sure what you think, but it seems like it must be a lot more common than we realize.
I must admit, this, as I said, was something that you try and remember for an exam, something that you try and think of lower down on the list. And in fact, there's very clear patient groups where this should be really high up there. And it's not an expensive test. It's not expensive treatment. And the impact is huge, considering that you might proceed to stem cell transplant before someone tests you.
Yeah, absolutely. Yeah, a real learning point there. So it remains for me to thank you and again thank the other speakers very much. This was really a very nice, a very, very nice session. I think I really enjoyed it. Please, can everybody take a few seconds to complete the Google response form that you will receive regarding some feedback. We have some comments from Tina Stick. Please check tubes needed for zinc and copper. Richardson no longer uses the royal blue tubes. And Jody says ceruloplasmin is falsely elevated by inflammation too. Okay, so, these things are all, have their innuendos and complexities and when to measure and if you can be fasting and if not and what you can eat beforehand. But I think this was really an excellent session. So thank you very, very much. And it remains for me to wish everybody in Cape Town a safe trip home if they are at home, because we have absolutely terrible storms, or just hope that you don't have leaking and flooding in your house. And if anyone has further questions, please feel free to email one of us. Thank you very much. All the best. Bye-bye.
Thank you.
Bye-bye.
Take care.